Let's jump right in. Welcome to this Anesthesia Learners Academy Explainer. Today, we're taking a magnifying glass to circulatory shock. We're going to rigorously break down the mechanics, the pathophysiology, and the management, looking at it strictly through a system failure model. So from hypovolemic and cardiogenic to obstructive and distributive, we are covering the whole shebang.
So here's the big question to kick things off. What actually happens when a patient's cells just suddenly start to suffocate? We're going to examine the exact physiological breakdown that kicks in when systemic oxygen demand vastly outstrips supply, putting our patient in immediate life-threatening danger. Here is our roadmap for today. We'll start by defining circulatory shock, then trace the pathophysiology and shock stages. Next, we'll dive right into pump and volume failures, followed by obstruction and distribution failures. After that, we'll cover recognizing the clinical signs and wrap it all up with resuscitation and management protocols. Section 1. Defining circulatory shock. Now, it's a super common trap to just watch the monitor and wait for the blood pressure to tank before calling it shock. But honestly, by the time you see that hypotension, the cells are already suffocating. Shock isn't just low BP. It's a profound, life-threatening state of tissue hypoperfusion. Basically, multiple organs are simultaneously starving for blood and oxygen, leading straight to cellular hypoxia. It is literally systemic cellular suffocation. To really grasp perfusion, we gotta look at the math. It all boils down to mean arterial pressure, or MAP, which is cardiac output multiplied by total peripheral resistance. In a clinical setting, you know the drill. Current guidelines tell us to target a MAP of 65 millimeters of mercury or higher. That's the magic number to ensure those organs are actually getting perfused. Section 2. Pathophysiology and shock stages. Let's see how this plays out over time. Shock doesn't just happen all at once. It's a progressive slide. In step 1, the compensated stage, a healthy adult can actually lose up to 15% of their blood volume, kind of like just donating blood, and their built-in compensatory mechanisms will completely mask the symptoms. But man, once those mechanisms are overwhelmed, the drop into step 2 is aggressively fast. The cells are totally starved of oxygen, forcing them into anaerobic metabolism, which spikes that lactic acid. Finally, if we don't intervene, we hit step 3, irreversible shock. This is where prolonged starvation causes end-organ dysfunction, multi-organ failure, and ultimately death. Moving to Section 3, pump and volume failures. To figure out the etiology here, it really helps to think of the cardiovascular system as a giant plumbing network that's prone to some very specific physical failures. The first one in our diagnostic rule of 4 is hypovolemic shock. Think of this as a total loss of water in the pipes. It's a volume failure caused by a sudden, massive drop in circulating blood volume. Now, this can be hemorrhagic, like active bleeding from trauma or a major surgery, or it could be non-hemorrhagic, like massive fluid loss from severe burns, extreme diarrhea, or vomiting. Either way, this critical loss of volume completely tanks the preload. And if the heart has nothing to pump, your cardiac output plummets. Mechanism number 2 is cardiogenic shock. If hypovolemia is an empty tank, cardiogenic shock is a broken motor. The heart itself just fails to adequately pump blood around the body. We usually see this as cardiomyopathic, typically triggered by an acute MI that completely wrecks myocardial contractility. But it can definitely be arrhythmic too, driven by crazy tachycardias or bradycardias. Or it could even be a sudden mechanical failure, like a blown valve or a ventricular septal defect. All right, Section 4, obstruction and distribution failures. What happens when the vessels themselves are the problem? Category 3 is obstructive shock. And this is exactly what it sounds like, a physical roadblock. It's a mechanical obstruction to cardiac outflow or filling. Picture a massive pulmonary embolism, a huge clot just blocking the pulmonary artery, or a cardiac tamponade, where fluid fills the pericardial sac and rapidly compresses the heart, literally stopping the chambers from expanding. The real tragedy here is that the pump is totally fine, the fluid is there, but a physical barrier, like a severely kinked hose, stops the flow entirely. Rounding out our rule of 4 is distributive shock. This is a capacity failure. The volume is normal, the pump is working, but the pipes have suddenly dialed up and expanded to 3 times their normal size. There just isn't enough fluid to fill this massive new space. The subtypes here are huge in the ICU. You've got septic shock, driven by an out-of-control inflammatory response to a severe infection. You've got anaphylactic shock, which is a severe allergic reaction dumping massive amounts of histamine, and neurogenic shock, usually from a high spinal cord injury that just completely wipes out the body's sympathetic tone. Now, when you're actually standing at the bedside, you're going to see two drastically different presentations: cold shock versus warm shock. This is your bedside cheat code. On one side, cold shock, so your hypovolemic, cardiogenic, and obstructive types. The body is desperately trying to keep the pressure up by clamping down, causing intense systemic vasoconstriction. That leaves the patient with cold, clammy, pale extremities. Contrast that with warm shock, which we see in distributive or early septic shock. Here you have massive pathological vasodilation and capillary leak. The resistance completely bottoms out, leaving the extremities warm and flushed. Spotting this difference immediately points you toward the underlying mechanism.
Section 5. Recognizing the clinical signs. As a clinician, you're basically a detective trying to reverse engineer symptoms to find the failing system. When a patient starts crashing, these classic signs are your flashing red lights. You're looking for hypotension, typically a BP dropping below 90/60. You'll see tachycardia, as the heart tries to compensate by beating over 100 times a minute, and tachypnea, with the patient breathing super fast to pull in more oxygen. Watch for oliguria, too, a sharp drop in urine output as the kidneys take a hit. Mentally, they might be agitated, confused, or completely unresponsive. And of course, your labs will show an elevated lactate, confirming those cells have shifted into that dangerous anaerobic metabolism we talked about. Section 6. Resuscitation and management protocols. Once you spot shock, rapid, protocolized resuscitation is literally the only way to stop the death spiral. Initial management is all about treating the root cause. First, optimize the airway and breathing. This cuts down the oxygen consumption of the respiratory muscles, saving that precious O2 for the vital organs. If it's a volume failure, you'd gotta rapidly run crystalloids like Ringer's lactate. For massive hemorrhage, we jump to a 1-to-1 ratio strategy for blood transfusions to replace both the volume and the clotting factors. In septic shock, the absolute priority is getting broad-spectrum antibiotics in within that first hour. Every minute you wait spikes mortality. And for anaphylaxis, you're pushing immediate IV steroids and allergy meds.
But what if dumping fluids in doesn't hit that target MAP? Well, that's when we bring in the heavy hitters, specific vasopressors and inotropes. It's all about picking the right agent based on which part of that MAP equation is failing. Need to clamp down the pipes and increase systemic vascular resistance? You reach for noradrenaline for that strong alpha receptor squeeze. On the flip side, if the pump is failing and you need to boost cardiac output, you'd go with dobutamine to leverage its beta-1 affinity and increase contractility. It's a highly precise pharmacological balancing act.
And look, this isn't just guesswork. Knowing the exact receptor affinities of these life-saving drips requires real academic rigor. That's exactly why foundational texts like Morgan and McHale's are still the absolute gold standard for clinicians. You have to ensure your interventions are deeply rooted in physiological science when you're navigating these life-or-death hemodynamics. Which brings us to a final, really critical question. If end organ hypoperfusion is the final common denominator of all shock, we have to ask ourselves, is your current resuscitation protocol merely treating the service symptoms? Are you just chasing a blood pressure number on a monitor, or are you truly reversing the cellular suffocation at the tissue level? I want to leave you with that thought to ponder during your next ICU rotation when you evaluate how effective your resuscitation efforts actually are. And that wraps up our explainer on the mechanics, pathophysiology, and management of circulatory shock. Please remember to like, subscribe, and share this resource with your colleagues so we can keep bringing you these structured deep dives. Keep learning, stay focused, and we'll catch you in the next explainer.